Thanks, everybody, for this opportunity. And I am not Daria Babushak, a wonderful and very knowledgeable person on this topic. And she has thankfully not actually delivered, but has had some preterm labor issues. So unable to travel. So obstetric adventures. But my mission today is to talk to you about predisposition syndromes to MDS and MPN, and I hope it's going to be overview with a few details and some useful knowledge. And I think as a way of introducing some background, I just wanted to frame it using a concept of clonal adaptive hematopoiesis. And this is really the common unifying denominator in predisposition to malignancy for inherited conditions as well as other malignant predisposition. So we really now recognize this phenomenon being one of normal aging. And clonal hematopoiesis is a condition where a stem cell acquires, how do I get it to not advance? Okay. Where it acquires a genetic or an epigenetic alteration conferring fitness, actually. And the picture is really meant to depict this funnily growing cactus in a desert, and it may be that microenvironmental pressures lead to this, so stem cell depletion or exhaustion, and lead to this clonal adaptive hematopoiesis. So within this, an oncogenic mutation is going to enhance its fitness, and I think that's just an important model to understand. So clonal hematopoiesis in the elderly is, we're now talking about patients who do not have a diagnosis of a blood disorder. And these are large population studies that showed an increasing proportion of people who accumulate somatic mutations with age. And I think you can appreciate from this slide that it really sort of starts at around the age of 50, but at 50, about 1% of patients will have evidence for clonal hematopoiesis. But by the age of 65, fully 10% of patients, of people, of normal individuals, will have clonal hematopoiesis. And they're probably also at increased risk of developing malignancies. And the types of mutations are those that we're probably largely familiar with as epigenetic modifying genes like DNMT3A, ASXL1, and TET2. And I think this is a really not necessarily unexpected, but really important recent observation. So the incidence of malignancies actually really mirrors age-related clonal hematopoiesis. And so here now you have MDS and MPN, and it really looks largely superimposable to that last figure that you saw. The median age of diagnosis is between 71 and 76 for MDS and in the 60s for MPN. And just to give you a sense of kind of the idea of clonal hematopoiesis and adaptation, this is actually data from patients with severe aplastic anemia. We think of this as an acquired immune-mediated disorder and not necessarily malignant, but we know that people acquire mutations in this setting, probably related to selective pressure. We now know in this population also, we think of sort of as non-malignant disease, a majority will get mutations, and these are mutations along the same spectrum as what we're familiar with. Again, ASXL1, DNMT3A, TET2, B-core you might be familiar with, and it does correlate with disease transformation, but can absolutely predate it. And I think a similar phenomenon will be seen in predisposition disorders, as you'll learn. So I'm going to focus a lot on the predispositions to MDS and a little bit about MPNs. So within the last few decades, an enormous amount of discovery has happened in these genetic predisposition syndromes. Close to 20 have been identified and can really be pretty diverse, but I think if you frame them in 3 broad categories, that may be helpful. So I'll focus not actually much on any individual one, but the ones in brown are the ones that we would really think is something you might want to have an index of suspicion for in adults. So there's the classical bone marrow failure syndromes, dyskeratosis congenita, Fanconi anemia. Many people have probably heard of these. And then the middle column are really these largely recently identified syndromes associated with a variety of genes. So most MDS in adults is sporadic. And you might be thinking, do I really need to worry about these genetic syndromes in adults? And I would say that if you frame it into patients, into the thought that MDS is largely a disease of the elderly, and the younger people are really kind of represented orphan disease with a very different potentially predisposition. And so I think I'm going to give you a few cautionary tales here, actually, and we'll kind of go through why it might be useful. So the first is a 34-year-old man. He has AML. He's in a complete remission but has persistent cytogenetic abnormalities, receives a match-related donor transplant, is thought to have relapsed at 13 months after transplant, but it turns out that he's entirely donor chimeric. And when they do a molecular analysis, there's a germline CBP alpha mutation in both the patient and his sister. In the second case, it's a 30-year-old man with aplastic anemia. He also is getting a match-related donor transplant, and the harvest is very hard from a bone marrow harvest. They try for a peripheral blood stem cell harvest, also very difficult. He has delayed engraftment, prolonged neutropenia, and ultimately dies of these complications, and subsequent evaluation showed short telomere lengths and a germline mutation in TERK. And the last case is one that people might be more familiar with. These are all published cases, but a 23-year-old woman with myelomonocytic leukemia received a transplant again from a sibling, has severe mucositis, skin desquamation, basically a lot of transplant-related morbidity and ultimately mortality, and found to have chromosomal fragility consistent with Fanconi anemia that had been unrecognized. So I think these are really the reasons why we would want to know some of this information in a practical way, because we would alter treatment and hopefully result in more favorable outcomes. So back to the practical, is there a specific age cutoff that can be used to guide screening? And I think that really the rule of thumb would be 50, and then you can sort of modify that according to age, family history, clinical history, and disease characteristics. And what am I talking about? You want to think about familial aggregation, so a detailed family history is helpful. We'll get to some details there. And also we'll look at some distinct cytogenetic and molecular characterizations that might make you think about it. But again, I think just having an index of suspicion in a younger patient is a really important starting point. So this is really a timeline to show you both how much has been discovered recently with 5 syndromes within the last 5 years. I mean, truly remarkable, but that it's really important to recognize that the vast majority of patients with a true syndrome will have one that's uncharacterized, and you can classify them as such. Really what it requires is frequent reassessment of disease in this age of really rapid discovery. And I think it's still okay to label those patients and possibly their family as having some sort of predisposition syndrome. So one might wonder what the benefits of establishing a true diagnosis is. The case reports are sort of the cautionary tale, but I think there is something to be said for diagnostic precision, particularly so some of these patients are at risk for other types of cancer, so it would change cancer screening and surveillance, and really, for the really young patients, some consideration about pre-implantation genetics, also thinking particularly about stem cell transplant, which is really probably the most practical consideration because it really could dramatically alter both timing of transplant, conditioning regimen, and donor selection. So what should you be looking for? So first point is that these are very insensitive. So helpful if you see them, but certainly the absence of any of these findings is not sufficient to rule out any of these disorders. But you can see the hypoplastic thumb on this patient, hopefully, and a cafe au lait spot, which is pretty subtle. This is a patient with adult recognized Fanconi anemia, an inherited disorder that we can sometimes identify in adulthood. For dyskeratosis congenita, you can see these nail abnormalities, oral leukoplakia, some premature graying, and GATA2 haploinsufficiency often associated with lymphedema. And actually, every time I revisit this topic, I think a lot about some of the patients that we've had over the years and whether we have seen some of these unrecognized disorders, whether we've unrecognized them. Historically, sort of family history or personal history that might be suggestive. This is the patient who comes with, a longstanding diagnosis of ITP. And now has multiple lineages affected, for example. That's one common scenario. For patients, when you're talking about family history, a strong family history of pulmonary fibrosis or cirrhosis, really very common in dyskeratosis congenita, and you kind of have to ask those questions to tease that out. Endocrinopathies often seen in Fanconi patients, and then frequent unusual infections, sort of mycobacterial, they're non-tuberculous, genital warts, highly prevalent in patients with GATA2 haploinsufficiency, as is lymphedema, and then unusual cancer histories. Head and neck cancer is very common in Fanconi families. So what about molecular and cytogenetic features? So the typical chromosomal abnormalities, you're going to have all this information as part of your standard workup. Monosomy 7, the others listed here, these are actually all very common in sporadic disease as well. So I think that has limited utility but can sort of be ancillary in terms of supporting your suspicion. And then other molecular findings, including the allelic mutations here in people who have access to a large panel of next-generation sequencing, you might see this, or just allele frequency. So if you see anything with an allele frequency, if your panel provides you with this information of about 50%, it can make you start thinking about whether this could be some inherited predisposition. So I'm treating a young adult with MDS, no dysmorphic features, or other findings suggestive of bone marrow failure syndrome, and they really don't have a family history that's strongly suggestive. So what should I test? And this is really, I guess, the bottom line. So the first category are these structural genomic analysis. Most of these, so just conventional cytogenetics, a conventional karyotype, most of us are getting those with our standard workup. Some people will get a SNP array as well in select cases. Functional screening would include, I mean, these are in the sort of I wouldn't want to miss it department. And Fanconi anemia is a chromosome breakage analysis, which you can send on peripheral blood, as well as telomere lengths. We typically measure this as a send-out test by fish, so a flow fish assay for telomere lengths, and you would expect it to be very short in the lymphocytes of a patient. And then PNH flow is actually helpful in that it would, it's very uncommonly seen in patients with predisposition syndromes, and that might steer you away from a big comprehensive workup if you find a PNH clone. So if you have a very high suspicion for Fanconi, for example, and for the genetic testing for predisposition syndrome, so this is item number 3 here, you actually want to make sure you do it on skin fibroblasts typically. So you're sure you're not contaminating it with acquired genetic abnormalities from the blood. And so you can do this by a small skin punch biopsy and cultured fibroblasts. If there's you can sometimes do it directly from a skin punch biopsy. It's just a little bit less sensitive. So the results are in. Now what? So, you know, this is largely in the land now of expert opinion, and I think just helpful to think about several different things. Referral to a specialty center is typically in order for proper management and genetic counseling. You know, thought of first-degree relatives and what implications it would have for them. Also screening. And upfront HLA typing and consideration of early transplant, particularly important for Fanconi anemia, using very specialized conditioning regimens. And likewise, actually, with dyskeratosis congenita. So with the last 3 slides, I'm just going to talk a little bit about predisposition to classical myeloproliferative neoplasms. You can see here from this nice pie chart that a small percentage of patients with MPN, but significant, have some familial predisposition, so about 7.6%. Phenotypically, they tend to be pretty indistinguishable from classical MPN, but I think it's important to at least recognize this and have some education so you can talk to your patients about it. So just to put it in the context, again, of this adaptive clonal hematopoiesis, by contrast, MPN are really driven by these driver mutations in more than 90% of patients. So JAK2, calreticulin, and MPL, virtually all patients, whether they have a familial predisposition or not, have these as acquired mutations and just have a predisposition. A very small percentage will have a germline inheritance of actual driver mutations. But for the most part, the mutations that you're familiar with, JAK2, V617F, calreticulin, and MPL, are going to be acquired mutations in this population. Genetic predisposition to classical MPN, 2 large flavors, those that give a predisposition to MPN driver mutations. The one that people are probably most familiar with and has the highest population attributable risk is the JAK2 V46.1 haplotype, very common. It's basically a SNP within the JAK2 gene and confers an increased risk of acquiring classical MPN. There are other SNPs, and very recently, the first demonstration of several genes whose expression led to a synergistic effect with these driver mutations has been described and just recently published in Nature Genetics. And what they found was this rare inherited duplication in a set of related families where two genes, these are ATG2B and GSKIP, had a synergistic effect with the acquired MPN mutations and produced a highly penetrant MPN syndrome. So I think that's new and novel and not necessarily part of a SNP. So, clinical characteristics of familial MPN. I think my time is short, so I'm going to summarize this. They're very indistinguishable, both in phenotype and clinical outcome, and management is counseling of patients. But honestly, it should be fairly reassuring because I think that we don't know that it would alter things or, with this rare group of disorders, necessarily necessitate any specific testing. So I'll just summarize by saying that adaptive clonal hematopoiesis really underlies this malignant predisposition to both acquired aplastic anemia, MDS, and MPN predisposition syndromes. MDS, rule of thumb is it's in younger patients. It can really alter your clinical decision-making, definitely worth having some high index of suspicion and doing a comprehensive workup or referring otherwise. An MPN predisposition, also fairly prevalent, but commonly doesn't change clinical management a great deal at this point. And I'll just stop there.